Patient, 67 years old, female, recurrent chest pain for 6 years and grade for 1 month. Risk factor is hypertension, diabetes. The test result shows low EGFR and BNP is normal. ECG showed T-wave inversion, ST dispersion is led to 3 the AVF, V2 and V6 and the normal ejection. We diagnose patients unstable angina pectoris, hypertension, diabetes. Next. From the LAO cranial position, we show the RCA is diffusely with a serious narrow lesion. Next. From the caudal and IO cranial position, we see the LCS is borderline lesion and the proximal OAD is a serial narrow lesion, and the middle of the LCAD is CTO with calcified lesion. Next. We also see the LAO cranial and the spinal position. Further test the above mentioned lesion. Next.
As you see today, our case is the chap vessel disease, and I think you'd like to see our today's angiography. Please show our today's angiography. Although the patients has the high risk level from the syntax score and is the good candidate for the CABG, but the patient family refused to perform the open chest surgery. So the family strongly against CABG and ask us for help. So for the trap lesion, we have the pre-procedure preparation. And first, for the procedure, although it's the equivalent coronary odotomy, but you can see from today's angiography, the right coronary, the flow is not good, and you can see the comparable flow from the both the side, because from the post-lateral, you can see the contralateral flow just from the circumflex to the PLA. And the left main is the Medina 010. It's not the true bifurcating lesion, but very long diffuse lesion from the ostium of LAD and extended to the distal LAD. And also you can see the CTO in the middle segment of the LAD. So it's really a tough case. And before that, our team, we just compare both of the side of the odotomy, and we just equivalent the beneficial and the risk ratio, and we decided to treat the ICA. The main reason is just because the ICA is the recipient vessel. You can see the donor flow from the circumflex. So if we want to PCI for the left coronary artery, and the circumflex is a dominant vessel, if the circumflex flow compromised, there will be a jeopardy for this patient. So ICA treat first, I think, is suitable and will be safe. This is what we did today. Okay, just show the next picture. You can see the wire, and this we use the transradial approach, use the 6 French. It's the M plus 0.75, and use the 2.0 and 2.5 balloon to pre-dilate the diffuse lung lesion just from the distal cracks to the ostium ICA. And the balloon expands well, and you can see flow also good. Patients tolerates well, and then we deployed the 4 stents just from the distal crux and to the osteo ICA, and the diameter of the stent just from the 2.25 and to the 3.5. Then we perform the post dilation, and you can see the final result of the ICA. For the IC PCI, we totally used the nearly less than 15 minutes, and the contrast volume less than 50 millimeters. So I think the patient is still well, hemodynamic stable. I think that will be good support for us to perform today's the tough case, the tough bone of the left coronary artery. So you can see the final result ICA. Although you can, next please. Okay, it's the, you can see it's the bilateral corneal angiography, because of the total occlusion in the middle segment of the LAD. But unfortunately, we seek to find the contralateral from the distal PTA uvula. It's also the common contralateral from the PDA to the just from the septal and then to the LAD. But because it's the equivalent distribution of the corneal artery, so we cannot find the contralateral collaterals from the distal ICA. It's fortunate. And the main the collateral is just from the ipsilateral from the obtuse marginal and to the second diagonal. And it's also the common epicardial collateral for the left coronary autonomy. But just is the, although the JCTO score is nearly 3, right, Dr. Wu? Is 3.
Yes,
so
3.
it's middle to high level. But I want to try use the anti-grid wiring. Then if the anti-grid wiring not succeed, I just to change my switch to my next strategy from the retrograde. Just to use this the challenging epicardial collaterals. So next, please. You can see from this the IO cranial. You cannot see very clearly the contralateral from ICA. Next. Okay, next. Okay, next. You can see the osteo-LAD also sharp lesion, just because we just avoid the ischemia when we perform the LAD middle CTO PCI, and we use the 2O balloon next to predilate the osteo lesion. This is 2O balloon. Next, please. Okay, seems better. Next, please. Okay, it's the wire and very difficult. And when I want to retrieve the wire, I feel just the resistance, like the something bite the wire. According to the my experience, that called the proximal segment of LAD, there must be some severe calcified plaque and also the very tortuous lesion. As you can see, the wire cannot extend the vessel to the street. It's calcified and also tortuous. Next, please. Unfortunately, you can see it's the fine cross microcatheter. Just want to follow, but you can see it's not succeed, cannot pass. And also sharp lesion also has the calcified plaque. So next, please. I use the 1.5 balloon to predilate. Next, please. Next, please. Next, please. You can see balloon not expand well, and also you can see the contrast staining. Seems that the lesion is very tough. So next, please. Try to use the double lumen catheter, the KDL, but you can see the wire, the softer tip wire field XT cannot engage the ostium plaque. So next, please. So I changed the guide segment, use the middle in the middleweight tip load guide wire. Seems better. Seems better. Okay, next, please. But unfortunately, the double lumen catheter, you see, it just also feel the resistance, and also from the anti-grid way, and also when I do want to retrieve this the KDL, I feel the strong resistance also bite the feeling. So next, please. So I just use a trapping balloon to retrieve the double lumen catheter. Next, please. Oh, sorry. Here is just what we do now, and I just successfully to switch our catheter from KDL to the fine cross, the single lumen catheter. Okay, Chip, that's what we did now, just here. It's the guy to, I don't want to escalation the wire tip because the guy second, the first guy second goes, I think, smoothly, just because the second wire is not in the previous channel. But I think it's very difficult to perform the parallel wire because the very tight lesion, I feel the wire bites by the proximal segment. And even the double lumen capacitor, when I try to insert and when I retrieve, the wire just cannot keep its place. So that's why I changed for the single capacitor. If I failed, maybe I will try use the double lumen capacitor to perform the parallel wiring again. It's different from the previous channel. I just want to nearby the septal side, just because of very sharp space. So it cannot tolerate the two. Although I use the self-range gallium capacitor, seesaw for the fine cross is also is suitable, but it's just a very sharp space cannot tolerate the two microcapacitor. So seesaw technique that will not work. I think so. That's why I just want to retrieve the previous microcapacitor. Okay, as you see now, chip the KDL just go here, cannot go anymore.
Yes, sometimes compared with only single lumen microcaster, the profile was smaller compared with double lumen caster. So the single lumen microcaster can go more distantly compared with double channel. If there is a severe dissection occurred, I want to use a double lumen caster. If there is no severe dissection, from my experience, I want to use a single lumen. Yeah, single.
Okay.
So you can use. Just because we cannot push the double lumen caster more distantly, so the benefit of the double lumen caster, we don't have any benefit.
Agree. I just trying to advance more. As you can see, calcified and also
yes,
touches.
it's quite difficult. It's quite difficult.
I just want to deep see the guide and to give some support. Okay, seems good.
No.
Okay, it's in the small branch. Usually I like use the more soft tip to, but as you can see, we only have the guide set here. Small resistance, but just too wide, deviate too much. I don't think there's a good channel. And
so, yes, I think the anti-grid wire tactic, it's a finger tactic just because we can feel some resistance and some stuck feeling. That means maybe in the fourth lumen or in the two lumen there is difference.
I do believe it's extra plug tracking. Okay, I think this channel looks better, right? But still deviate from the distal.
So you can change another view.
Okay, another view, please. Another view,
so
please.
anti-grid wire tactic, we should pay attention to the hematoma during the anti-grid wire tactic. If we perform for several times, we can see maybe.
Please. This channel seems good. I need
Now change RIO cranial. RIO cranial.
RIO cranial, please.
That's because we use angel-guided PCI. This is a 2D, but the vessel was 3D.
Yeah.
Okay.
Also, yeah. The extra pack. Okay, so Chief, I like to try to use the retrograde.
Sure.
Maybe cannot work now.
Okay, no problem.
Okay. Before that, because it's only a 7-fan gallium capacitor, so cannot tolerate the KDL and also the another retrograde microcapacitor. I need to retrieve.
Okay.
Also, we can use the ping pong, but you see, when I want to retrieve this, the KDL, I feel strong resistance. I should to put back the gallium capacitor and slowly. ACT more than 400.
Okay.
Yes, I think it's okay.
If we perform PCI for CTO lesion with a retrograde wire technique, we should pay attention to the thrombosis during the procedure, just because we use a longer microcatheter with procedure time was longer.
Yeah.
Like
because
you should make the wire in LED proximal first. There is a marker. So use a single lumen microcatheter.
Single lumen catheter, I think so.
So you don't need to use two wire in the LED. Which kind of wire?
Because just when I want to retrieve the KDL, it's bite so strong, so I just lost my wire position.
Okay.
Yeah, now I just want to deliver
Okay,
the
okay.
wire.
Yeah, it's okay.
Even use the retrograde, even try to use antigrade approach. We also need the antigrade preparation because the instant pass 1.7 French has the very small profile, the small tip, and also the passing profile. So that's why I treated the ICA first, just because I just plot the procedure. My strategy is if the antigrade wiring failed, we will use the retrograde way, and circumflex will be our choice. If we leave the ICA alone, and there will be a jeopardy for this patient. So now I think it's no problem. Yeah, I will follow the market, also very touches, but okay, you can see the tracking of the market is good. I need more support for this. Okay, I think for the very touches epicardioquarters 203, I think the soft tip, I think will be very safe, not good. Only step to 0, but doesn't mean we don't have any choice. Before that, I will make sure that the epicardio will be okay. Seems no damage from the, no contrast, the staining or perforate. I think it's okay. Okay, try use the surfing technique from the distal PDA. Yeah, previous view, please. Okay.
Use a longer microcaster,
Yeah.
1.7.
Maybe 1.7 French,
Yes.
but
1.7 French.
150
Just
centimeter
before,
is
yeah.
enough. Okay.
Just from the angel, we can find the
Yeah.
distal
回到碗冲好给我 please.
septal
定这
collateral
个
was
刚造
very
影那个
small. Maybe we can use a smaller profile microcaster. Yes. Okay.
Okay,
Okay.
Michael Kester, please.
So previous angel.
You will know.
Pay attention. Why?
Yeah. Why, please?
Okay.
Because just the 1.7 French Michael Kester maybe damaged the field resistance where I want to retrieve the wire. So I use the extension wire to deliver this one.
Even though because we want to use a distal septal branch, the diameter was very small. If we want to use a microcaster go through the collateral,